All right, let's dive right into this explainer and unravel a pretty complex yet absolutely fascinating medical mystery, Peutz-Jeghers syndrome. This is one of those conditions that perfectly illustrates how the tiniest microscopic quirks in our DNA can ripple outwards, fundamentally affecting the entire human body over the course of a lifetime. So, we're starting off with a puzzling clinical mystery. Imagine a kid comes into the clinic with just some simple dark spots, basically a kind of freckling popping up around their mouth or maybe on their fingers. On the surface, right, it seems completely harmless. And yet, to a trained eye, those little spots are actually an early, flashing warning light for invisible, internal threats that are going to unfold over the coming decades.
Here is our agenda for today. We'll be covering the telltale signs, the genetic root of the disease, lifetime cancer risks, diagnostic mimics, and we'll wrap up with surveillance and treatment.
Section 1. The Telltale Signs. To lay the groundwork here, Peutz-Jeghers syndrome, or PJS, is a rare genetic condition defined by a really specific triad. You have unique growths in the gut called hamartomatous gastrointestinal polyps, that distinctive mucocutaneous pigmentation we just mentioned, and a severely elevated predisposition to various cancers. Now, it has an autosomal dominant inheritance pattern. That means you only need to inherit the mutated gene from one parent to be affected, though, we absolutely do see spontaneous de novo cases as well. So how do doctors officially diagnose PJS? They use the World Health Organization's specific criteria. Because symptoms can vary wildly between patients, even within the exact same family, the WHO relies on a combination of these confirmed polyps, the classic pigmentation, and family history. Hitting any of these specific combinations basically locks in that clinical diagnosis. Let's look a little closer at that pigmentation. These distinct dark blue to brown spots, which are clinically known as macules, are crucial diagnostic clues. They typically show up in early childhood, very often before a kid even hits 5 years old, and they concentrate right around the mouth, the eyes, nostrils, and even on the fingers and toes. What's really fascinating here is that these spots are utterly harmless on their own, and they actually tend to fade away during puberty and adulthood. But recognizing them early, that is absolutely vital, because they almost always predate the really severe gastrointestinal symptoms. Moving to Section 2, the genetic root. Okay, the crucial point to understand is that a staggering 90% of PGS cases are caused by a mutation in just one single gene. Specifically, we're talking about a germline mutation in a tumor suppressor gene called STK11, which sits on chromosome 19. Normally, STK11 helps regulate cell polarity, cell cycle arrest, and certain cellular pathways. But when it's mutated, that vital regulation just totally breaks down. And that sets the stage for uninhibited polyp growth and, eventually, malignancies. When a pathologist looks at one of these PJS polyps under the microscope, the dead giveaway is this beautiful but honestly very dangerous tree-like arborization. It literally looks like branching, compact, smooth muscle bundles dividing lobules of relatively normal glandular mucosa. That totally unique architecture is exactly what classifies a hamartomatous PJS polyp. And keep in mind, these polyps absolutely love the small intestine, specifically the jejunum and ileum, though they really can pop up anywhere from the stomach all the way down to the colon. But here's the thing, this genetic mutation doesn't just cause polyps in the gut. It also sparks these highly unique gonadal tumors in children. In young girls, we see ovarian sex cord tumors with annular tubules, or SCT8s. In young boys, large calcifying Sertoli cell tumors can develop in the testes. And because these specialized tumors actually secrete estrogen, they can trigger precocious early puberty in girls or cause gynecomastia and advanced skeletal aging in boys. It's just a prime example of how systemic this genetic error really is. Section 3, lifetime cancer risks. Now, even before cancer develops, those growing gastrointestinal polyps pose a massive physical threat to the patient. They face a staggering 44% risk of intussusception by age 10, and that jumps to 50% by age 20. Intussusception is a life-threatening medical emergency. Basically, a large polyp acts like a lead weight, and it physically telescopes the bowel into itself. This causes severe obstruction, agonizing pain, and historically, it required repeated emergency open abdominal surgeries and bowel resections. Then we get to the sheer scale of the lifetime cancer risk, which is frankly staggering. A meta-analysis shows these patients face over an 80% overall cancer risk by the time they hit 70. Just look at these numbers for a second. A 54% cumulative risk for breast cancer, which, by the way, totally rivals the risks we see in BRCA mutations. There's a 39% risk for colorectal cancer and a really alarming 36% risk for pancreatic cancer.
This perfectly demonstrates exactly why this syndrome demands such rigorous lifelong medical attention. Females with PJS also carry some significant, very specialized risks for rare gynecological cancers. So, beyond those standard risks, there is a 10% risk of developing adenoma malignum. That's a very rare, super aggressive form of cervical cancer that can be really tricky to diagnose on standard biopsies. They also face a 21% risk of ovarian cancer. All of this makes standard gynecological checkups woefully insufficient for these patients.
Section 4. Mimics and lookalikes.
Because the stakes are so high, it is incredibly easy and dangerous to confuse a PJS polyp with another type of hamartomatous growth called a juvenile polyp. But a well-trained pathologist can spot the difference. While PJS polyps feature that dense, tree-like compact muscle branching we talked about, juvenile polyps lack that prominent arborization. Instead, they feature an inflamed, loose edematostroma with noticeable cystic dilation. Getting this identification right is absolutely crucial because it changes the entire genetic investigation for the patient. Similarly, mucosal prolapse polyps can look a lot like PJS polyps, especially when they're in the colon. However, their internal architecture gives them away. In a mucosal prolapse polyp, the smooth muscle is in total disarray, kind of just actively wrapping around individual crypts, rather than creating that cleanly structured lobular architecture that is entirely unique to Peutz-Jeghers syndrome. And finally, Section 5, Surveillance and Treatment. This highly structured, lifelong timeline of surveillance is exactly how we replace fear with action. Because symptoms start so early, the guidelines aggressively target the risks from childhood onward. By age 8, kids are already getting baseline upper and lower endoscopies and small bowel imaging. At age 10, annual testicular exams for boys kick off. Once patients hit 18, rigorous pelvic exams for females start up, and by 30, the protocol just shifts into high gear with intensive breast cancer and pancreatic imaging. It is an intense regimen, no doubt about it, but this meticulous schedule is what actively catches growing polyps and early-stage cancers before they can become fatal. And the technological leap we've made here is absolutely phenomenal. Historically, trying to find polyps deep in the small intestine meant using heavy radiation CT scans or these really clunky barium X-rays. But today, doctors use video capsule endoscopy. The patient literally just swallows a pill-sized camera that provides stunning, high-resolution imaging of the deepest parts of the small intestine. It's entirely non-invasive, and it doesn't use a single drop of radiation.
This technology sets up an incredible two-step treatment strategy. Step 1, you locate the exact position of the hidden polyp using that capsule endoscopy or an MRI. Step 2, you extract it without scalpels. Gastroenterologists now use balloon-assisted enteroscopy. It's this specialized scope that inches its way deep into the small bowel to snare and remove the polyp, which means patients no longer have to undergo repeated, traumatic, open abdominal surgeries just to clear their bowel of obstructions. It's a real game changer. Beyond just watching and waiting, patients and their care teams can take back control with aggressive preventative strategies. Regular polypectomies clear the gut of physical hazards. And given that BRCA B-level breast cancer risk we mentioned, prophylactic mastectomies are absolutely on the table, as are risk-reducing gynecological surgeries, like removing the ovaries and fallopian tubes. Furthermore, because this is an autosomal dominant condition, genetic testing of all first-degree relatives allows families to catch that STK11 mutation in siblings or children long before the first polyp ever has a chance to cause a problem.
We've seen the incredible danger of Peutz-Jeghers syndrome today, from those childhood spots to lifelong cancer risks. But as you reflect on this explainer, consider how the power of modern pathological surveillance gives patients the ultimate upper hand. By understanding exactly what is broken in the STK11 gene, we've engineered a system of capsule cameras, specialized scopes, and targeted imaging that intercepts the disease at every single pass. It's a brilliant testament to how knowledge literally saves lives. But it leaves us with a provocative question. As genetic mapping becomes cheaper and more accessible, how many other seemingly harmless childhood traits are actually roadmaps to our medical future?